You know that feeling, right? When you really want to get your head around something complex, see the big picture, but without drowning in details.
Yeah, exactly.
Well, that's what we aim for here. We dig through the information, the studies, all of it, to bring you those key insights, those moments where it just clicks. No information overload.
And today, we're diving into something that trips a lot of people up.
Mm-hmm.
Figuring out the different psychiatric care settings here in the U.S. We're using a really detailed chapter as our guide.
Right.
And our mission, basically, is to map it out for you. We want to give you a clear understanding of the types of care out there, how the whole system kind of grew into what it is, and some of the real struggles people face trying to get help.
Okay, let's unpack that. Because think about it, if you've got, I don't know, a sore throat that won't quit,
Mm-hmm.
you generally know the steps, right? Go to the doctor, maybe get a test, get a prescription. Pretty straightforward, usually.
Yeah, usually.
But for mental health stuff, the path often feels like, well, way less clear, doesn't it?
That's a really key difference to start with. It's not that simple A to B path, like with a physical issue.
Mm-hmm.
When it comes to mental well-being, there are several things tangled together.
Like what?
Well, first, there's the huge impact of stigma.
Yeah.
Just the worry about being judged, how people might see you.
Right.
It makes people hide what they're going through.
Right. Keep it quiet.
Exactly. And because people don't talk about it openly, it makes it harder for everyone else to even know where to start looking for help if they need it. There isn't that shared knowledge base.
And then sometimes the illness itself makes it hard to even see you need help.
Precisely. With some severe conditions like, say, schizophrenia, there's something called anosognosia.
Anosognosia.
Yeah, it's basically a lack of awareness about the illness itself. The person just doesn't recognize they're ill. So you can imagine how hard that makes it to accept treatment.
Wow, yeah.
And then think about something like major depressive disorder. The core symptoms like zero motivation, feeling totally hopeless, no energy, those very symptoms can stop someone from taking that first step to get help.
It's like a catch-22.
It really is. You feel awful, but the awfulness itself stops you from getting help for it.
That's incredibly tough.
It is. And then there's the overlap with physical symptoms. Anxiety, for instance, can cause things like a racing heart, dizziness.
Right, you might think it's a heart attack or something.
Exactly. So because diagnosing mental health conditions often relies more on what someone reports experiencing, not like a definitive blood test, doctors first need to rule out any physical cause, which is important, obviously, but it can also, unfortunately, delay getting the right psychiatric care.
And this is all playing out in this sort of unique American system, this mix of public and private health care, which adds another layer of complexity.
Yeah, definitely. This public-private mix has deep roots. If you go way back, the first attempts at organized care were the asylums, started before the Civil War.
Asylums. They have such a negative image now.
They do, but they actually started with good intentions. People believed folks could recover and that the state should help care for those considered insane back then. But the key thing to take away is that even those early efforts show how long and honestly still ongoing the journey towards effective community-based care has been.
But the reality inside those places probably wasn't great, even early on.
Oh, not at all. The treatments we have now, they just didn't exist. And there was basically no care available outside those walls.
Yeah.
Fast forward to the 1950s, your options were stark. See a private psychiatrist if you had the money, or end up in these massive state mental hospitals.
What are we talking?
At their peak, around 550,000 patients nationwide in state hospitals. Tragically, many people with serious disabilities just got stuck there, permanently institutionalized.
Wow. So what started to shift that?
Well, the 1960s, the whole Great Society era, brought us Medicare and Medicaid. Medicaid was particularly significant for mental health.
How so?
It started covering short psychiatric stays in general hospitals, like a regular hospital psych ward, and also long-term care in nursing homes. But, and this is really important, it generally did not pay for long stays in the big standalone psychiatric hospitals.
Ah, so the money trail shifted.
Exactly.
Yeah.
Because Medicaid wouldn't fund long-term stays in those specialized state hospitals, it kind of pushed the system, financially speaking, towards using general hospital psych units or nursing homes for some patients.
So it encouraged moving people out of the big institutions, but maybe not always to the best alternative.
You could say that. It created this financial reason to treat people elsewhere, even if those places weren't perfectly set up for long-term mental health needs. This was sort of the beginning of deinstitutionalization, but maybe not quite as planned.
Okay. Was there a specific moment that really accelerated that shift?
Yeah. A huge one was the Olmstead decision in 1999. The Supreme Court basically ruled that keeping people institutionalized unnecessarily when community services were available was a form of segregation.
Under the ADA, right, the Americans with Disabilities Act.
Precisely. It framed mental illness as a disability under the ADA and established the right for people with disabilities, including mental illness, to live in the community if possible.
So that legal ruling really mandated looking for alternatives to institutions.
It did. It pushed for the development, though it was gradual and honestly still isn't fully complete, of state and county community care systems. The idea was these systems would take over much of the role of the big state hospitals.
And did the number of state hospitals go down?
Significantly.
Yeah.
From 322 in 1950 down to just 188 by 2015. Now, how these community systems are set up varies a lot, state by state, even county by county. Like in Ohio, you have a state department overseeing things, but then county boards manage services more locally.
And it wasn't just laws and policies changing, right? Treatment itself got better.
Oh, absolutely. The development of psychiatric medications in the second half of the 20th century was revolutionary. Chlorpromazine, the first antipsychotic, came out in the early 50s.
Thorazine, right.
That's the one. It was a game changer. It allowed many more people to actually leave long-term hospitals. Then, over time, more drugs came along for psychosis, depression, anxiety, a whole range of conditions.
So treatment could actually happen outside the hospital walls more often.
Exactly. It meant care could increasingly be delivered in outpatient settings, not just by psychiatrists, but sometimes even primary care doctors could manage milder cases.
Okay, so that history gives us some important context. Let's shift to the present day then. What does that outpatient landscape look like now? If someone's worried, where's the first stop typically?
For a lot of people, yeah, the first stop is their primary care provider, their PCP.
Family doctor, nurse practitioner.
Right, someone in that familiar doctor's office setting. And there are good reasons for that. It feels less stigmatizing for many than going straight to a mental health specialist.
Less intimidating.
Definitely.
Yeah.
And like we said, sometimes the first signs look physical anyway, so it makes sense to start there.
But are there downsides to relying only on a PCP for mental health? I mean, they're juggling everything.
That's a fair point. Time is a big one. Primary care visits are often short, making it tough to do a really thorough mental health assessment.
Yeah, they've got like 15 minutes sometimes.
Right. And while they have broad medical knowledge, their specific training in psychiatry is usually limited compared to a specialist. So they're a crucial doorway into the system, great for milder issues or initial support, but maybe not equipped for the really complex stuff on their own.
Okay. Now, I've heard the term patient-centered medical homes, PCMHs. How do they fit in? Are they trying to bridge that gap?
They are, yes. PCMH has got a big push with the Affordable Care Act. The whole idea is to integrate care, better physical health, behavioral health, social needs, all coordinated together.
That's good in theory. What does it actually mean?
Well, they're built around 5 main ideas. Comprehensive care for all needs, being patient-centered, meaning focused on your specific needs and preferences. Coordinating care across different doctors and services, being accessible, like maybe having evening hours or email access, and focusing on quality and safety using evidence-based approaches.
So trying to break down those silos between, say, your GP and your therapist.
Exactly. Making it feel more like one team looking after the whole person.
What about community mental health centers, CMHCs? They sound really important for community-level care.
Oh, absolutely. CMHCs came out of the Community Mental Health Centers Act back in 1963. That was a major policy shift towards community care.
Did it work as planned initially?
Well, the funding never quite matched the original grand vision, but it still marked a huge change in direction. Nowadays, CMHCs are usually run and funded by state mental health departments, maybe with some local money too.
And who do they typically serve?
Because of how they're funded, they often prioritize people with the most serious mental health needs, and they usually use a sliding scale for fees based on income.
So more accessible for people with limited resources?
That's the goal. Think of them as aiming to be a sort of one-stop shop for a wide range of community mental health needs.
And what kind of services are we talking about at a CMHC?
It's pretty comprehensive. Things like assessment, diagnosis, counseling individual or group therapy, case management, which is huge, helping people connect with housing, jobs, other support.
Like a navigator.
Kind of, yeah. Also medication management, education about conditions, rehabilitation services focusing on recovery and daily functioning, sometimes even job support. Many serve all ages. Others might specialize, like in kids or older adults.
You mentioned psychiatric rehabilitation. Is that different from what a CMHC generally offers?
It's at a more specific focus, usually for people with diagnosed serious mental illness.
Hmm.
It's less about just managing symptoms and more about recovery and reintegration into the community.
So life skills, social skills.
Exactly. Helping people develop social emotional thinking skills needed to live and work independently. Training. Help finding resources like housing or jobs, creating supportive environments. That's the focus.
Okay. What if someone needs help but has trouble leaving their home? Is there care available at home?
Yes, that's psychiatric home care. Qualified professionals, often mental health nurses, provide services right in the patient's home.
Who arranges that?
Often it's coordinated through a CMHC or maybe an agency like a visiting nurse service. It can be really helpful for people who are homebound or just feel more comfortable receiving care there. It can sometimes even prevent hospitalizations.
Are there specific requirements to qualify?
Usually, yeah. Things like having a formal psychiatric diagnosis, being under a PCP's care, and meeting the definition of homebound. Though, interestingly, Medicare has a few exceptions to being strictly homebound. Like you can still go to church or get your hair done.
Okay, good to know. Now, somewhere between weekly therapy and being in the hospital 24/7, there are these intermediate options, right? IOPs and PHPs.
Right. Intensive outpatient programs, IOPs, and partial hospitalization programs, PHPs. They offer more support than standard outpatient. But you still go home each day.
What's the main difference between them?
It's mostly the time commitment. Both run several days a week, but IOPs are usually shorter sessions, maybe 3 hours a day. PHPs are more intense, often like 6 hours a day.
Yeah.
That's why they call it partial hospitalization.
So PHP is almost like a full day program.
Pretty much. Both offer structured activities, medical supervision, different kinds of therapy, individual, group, maybe art or occupational therapy run by a whole team. And they keep a close eye on how people are doing in case they actually need to step up to full inpatient care.
Nurses seem absolutely vital in all these outpatient
Oh,
settings.
completely. Psychiatric mental health RNs in outpatient, they're key members of the team. They help create care plans, provide direct care, do assessments, often lead educational groups for patients and families.
And knowing the local resources must be crucial too.
Hugely important. Knowing about shelters, food banks, job programs, support groups, and connecting patients to them, that's a massive part of their role in the community.
And then there are the advanced practice nurses.
Yes, the PMH APRNs, that includes nurse practitioners and clinical nurse specialists. They have more advanced training, so they can assess, diagnose, and treat, including prescribing medication.
So they can function somewhat like a psychiatrist in that regard.
In terms of assessment, diagnosis, and prescribing, yes. And actually, in many community health centers, you'll find more APRNs than psychiatrists. They play a huge role in providing accessible, preventative mental health care.
Okay, so that outpatient spectrum is really broad, but sometimes that's not enough and someone needs round-the-clock care. Let's talk about inpatient settings.
Right. Inpatient psychiatric care itself has changed a lot over the last, say, 40 years. There was a boom in the 80s, more psych units in general hospitals, more private psych hospitals opening.
And then,
Then things shifted in the mid-90s.
okay.
Managed care came in. Insurance started putting tighter limits on stays. And those outpatient alternatives like PHPs became more common and effective. So inpatient capacity actually declined quite a bit.
So what's inpatient care primarily for now?
It's the most intensive level. We're talking 24-hour nursing care in a safe, structured place. It's for acute crises, active suicidal or homicidal thoughts, severe agitation, needing close watching during med changes, crisis stabilization, detox from substances sometimes, or behaviors that just can't be managed safely outside.
Where do referrals usually come from?
All sorts of places. PCPs, outpatient therapists, CMHCs, ERs, sometimes nursing homes. The actual admission is usually handled by a psychiatrist, though sometimes a PCP could admit to a psych unit in a general hospital if they have privileges.
And admission isn't always voluntary, right?
Correct. People can agree to come in voluntarily, or they can be admitted involuntarily based on specific legal criteria, which differ state by state, basically, if they're deemed a danger to themselves or others, or gravely disabled. That's a whole topic in itself.
And the units themselves can be different, locked versus unlocked.
Yeah. Unlocked units allow more freedom of movement. Locked units are for safety, to prevent people from leaving if they're high risk. That's called elopement. Some places also have psychiatric intensive care units, or PICUs, for even higher levels of monitoring for those at extreme risk.
The environment itself must be part of the treatment.
Absolutely. They talk about the therapeutic milieu. It's the whole environment, the physical space, the interactions between patients and staff, the activities all designed to be safe, supportive, and promote recovery.
Teamwork sounds essential.
Crucial. You have this interprofessional team, psychiatrists, psychologists, social workers, OTs, recreational therapists, nurses, techs, all working together. The RN often coordinates the day-to-day care, and the whole team meets regularly to discuss each patient's progress and plan.
What's a typical day like on an inpatient unit?
It's usually very structured. Scheduled meals, medication times, different therapeutic activities, group therapy, maybe some individual therapy. If you're under 18, there's usually school time built in.
And patients have rights, obviously.
Yes, very specific rights protected by law. Things like the right to dignity, to be involved in your treatment plan, usually the right to refuse treatment unless it's an emergency or court-ordered, the right to request discharge, protection from harm, access to legal counsel, confidentiality, and always the right to the least restrictive treatment necessary.
What about the physical space? Does it look like a typical hospital room?
Less so these days, usually. Safety is paramount. So you'll see things like breakaway shower heads or closet rods to prevent hanging, enclosed pipes, locked windows, maybe platform beds, rounded corners on furniture, all designed to minimize risks.
And when someone first comes in?
There's an initial medical workup to check for any physical health problems that might be contributing or co-occurring. Then the whole team collaborates on a treatment plan. The main goals initially are always crisis intervention, stabilizing the acute symptoms, and keeping everyone safe.
Treatment isn't just about meds, though.
Definitely not. Med management is often key, but it's only one part. There's individual therapy, and group therapy is huge groups for coping skills, occupational therapy groups for daily living skills, psychoeducational groups where you learn about the illness, meds, recovery strategies.
How long do people usually stay?
It varies a lot, but national averages are maybe around 8 days for mental health, a bit less, maybe 4 or 5 days, for substance use, detox, and stabilization. Sometimes they use therapeutic passes, letting someone leave for a short supervised time, or privilege systems to encourage progress.
And getting ready to leave, that starts early.
It absolutely should. Discharge planning ideally begins right from admission. It's all about teamwork between the inpatient team, the patient, their family or support system, and whoever will be providing care outpatient.
What does that involve?
Setting up follow-up appointments, making sure they have prescriptions and can get their meds, education about their condition and ongoing care, sorting out living arrangements if needed. The whole point is a smooth transition back to the community to reduce the chance of needing to come back.
That treatment team sounds really diverse.
It is. You've got RNs, specialized psych nurses, psych nurse practitioners, psychiatrists, psychologists, social workers, counselors, OTs, PTs, recreational therapists, pharmacists, medical doctors, behavioral techs, chaplains, even peer specialists, sometimes people with lived experience. Each brings a different skill set.
Okay. Beyond these general settings, are there places that specialize even further for specific groups?
Yes, definitely. There's pediatric psychiatric care for kids and teens, similar treatments, but in age-appropriate settings with lots of family involvement and school continuation.
Makes sense.
Then geriatric psychiatric care for older adults, focusing on how aging interacts with mental health, physical illness, dementia, loss, trying to maintain strengths and independence safely.
What about veterans?
The Veterans Administration, the VA, provides federally funded care, including mental health services, for active military and eligible veterans. They deal with a lot of PTSD, which historically was called things like soldier's heart or shell shock. Sadly, rates are still high.
And forensic settings.
That's care within the criminal justice system. Mental illness and substance use rates are incredibly high in jails and prisons. Treatment happens there, or sometimes in specialized state hospitals. It's a stark fact that in most states, jails and prisons now house more people with serious mental illness than state hospitals do.
That's shocking.
It is. State hospitals also treat people found not guilty by reason of insanity, like the Andrea Yates case, which many people might remember.
And specific places for addiction treatment?
Right. Alcohol and drug use disorders can be treated in general settings, but there are also specialized centers just for that. And the need is huge. Lots of people who need treatment don't get it. These centers offer outpatient therapies, but inpatient is often needed for safe alcohol detox or more intensive drug rehab.
It's disturbing to think about the overlap between mental illness and incarceration. Shifting gears a bit, what about things people can do for themselves outside the formal system? Self-help.
Self-help and lifestyle choices can make a real difference. Things like getting enough sleep, eating well, exercise, limiting alcohol or drugs. They don't cure disorders, but they can definitely support overall well-being and recovery.
And support groups.
Huge. There's a massive network of voluntary self-help groups, completely separate from the formal healthcare system. It really started with Alcoholics Anonymous, AA. But now there are groups for almost everything: anxiety, depression, bipolar disorder, supporting family members.
What do they offer?
It's that combination of education, connection, knowing you're not alone, and practical support from people who really get it because they've been there. Peer support is powerful.
And organizations like NAMI.
Yes, consumer and family groups like the National Alliance on Mental Illness are incredibly important. They advocate for rights, fight stigma, push for better policies, promote recovery-focused care, and offer amazing support and education for individuals and families. They've really helped shape how we approach mental health care.
So we've talked about all these different services, but the big question for many is, how do you pay for it in the U.S.?
Ah, yes, the crucial question. It's a complex mix of private insurance and public programs. The Affordable Care Act, the ACA, made some big changes, like stopping insurers from denying coverage for pre-existing conditions, letting young adults stay on parents' plans longer, improving Medicare drug coverage, helping small businesses offer insurance, and pushing for coverage of preventive services like depression screening.
And public programs.
Key ones are Medicare, mostly for people 65 plus or with certain disabilities, then Medicaid for people with low income, but the rules and what's covered vary a lot by state. It generally covers inpatient, PCP visits, care for those under 21.
What about Social Security?
Social Security provides disability benefits. There's SSDI, disability insurance, if you have enough work history and a long-term disability prevents you from working. Psychiatric diagnoses are common among recipients. And there's SSI, supplemental security income for low-income adults, blind, or disabled people who meet strict financial limits.
So options exist, but it still sounds like cost can be a major barrier.
It absolutely remains a significant challenge for many, despite these programs. Financial hurdles are still a huge reason why people don't get the mental health care they need.
It seems like even with this wide range of settings and services we've discussed, just navigating it all, getting access, it's still really complicated.
That's definitely a key takeaway. Even with all the progress, getting access is tough. You got the stigma we talked about. Sometimes there just aren't services nearby, especially in rural areas. The cost is a barrier, and the system itself can be confusing to navigate.
So what's the vision for the future? Where do we want to get to?
Well, the vision really is a future where mental health is seen as just as vital as physical health, where care is driven by consumers and families themselves, where we eliminate the disparities in who gets care, where we screen early and intervene early, where everyone gets excellent evidence-based care, and research keeps making that care even better, and where we use technology smartly to improve access and information.
That sounds like a worthy goal.
It is. And psychiatric nurses, because they understand that mix of biological, psychological, social factors, they're really uniquely positioned to help lead the way in making that vision a reality.
So, yeah, it can feel like a maze navigating all these psychiatric care settings in the U.S., but hopefully understanding the different options, how we got here, and the factors involved gives you a better map. It's clear there's a whole spectrum of care, from talking to your family doctor all the way to specialized inpatient units and community programs designed for different needs. We really hope this deep dive gave you a solid starting point, maybe spark some questions for you to explore further.
And I think it's worth remembering that this system is still evolving. It's crucial we all keep thinking about how we can push for better access, finally get rid of the stigma, and make sure everyone who needs help gets that comprehensive, effective support. That continued progress is just so important.